Assalamu alaikum. Welcome to the second sections of this lecture about diseases of the uterus. So we will now talk about malignant conditions of the uterus. So 90% of uterine malignancies are composed of adenocarcinomas. So remember from our lecture on neoplasia, adeno means gland and carcinoma means malignant epithelial tumors. So these are malignancies of the endometrial glands. Endometrial adenocarcinomas, the majority can be divided into two types. So type 1 includes endometrioid carcinomas and the precursor, which is atypical hyperplasia. And then type 2 carcinomas, which include serous and clear cell carcinomas. There's multiple other types of endometrial cancers, but type 1 and 2 are the most important ones, so we will limit our discussion to these two. The remaining 10% of uterine malignancies are sarcomas. So again, remember from our lecture on neoplasia, sarcomas of malignant tumors of the mesenchymal tissues. Most of these uterine sarcomas are leiomyosarcomas, which are sarcomas of the smooth muscle that originate from the myometrium. There are also stromal cell sarcomas, which originate from the endometrial stroma, and then other rare types. But for the purpose of this lecture, we will limit our discussion to leiomyosarcomas. So endometrial adenocarcinomas, they are the most prevalent gynecological malignancy, and they are the cause of significant morbidity and mortality. Patients with endometrial carcinoma usually present with postmenopausal bleeding. Okay, this is very important. Any menopausal patient that presents with bleeding, an endometrial carcinoma should be excluded. Okay, sometimes endometrial carcinomas arise in premenopausal bleeding, and then it will present itself as abnormal uterine bleeding. How do we diagnose endometrial carcinoma? This is very important. An endometrial sampling, a biopsy, is necessary to confirm or exclude the diagnosis of endometrial carcinoma. Ultrasound imaging can be done and can show a thickened endometrium, but this finding is neither specific nor sensitive because many different things can cause a thickened endometrium, including benign polyps, thick secretory benign endometrium, etc. And a thin endometrium on ultrasound does not rule out a carcinoma. So the type 2 carcinomas, which we will discuss later, actually present with a thin endometrium. So an ultrasound can be done, but it should not change the fact that an endometrial biopsy should be planned for any patient that has postmenopausal bleeding. So I've prepared this specific slide with an alarm bell. Okay, if you're going to remember one thing from this lecture, it is this. Postmenopausal bleeding means endometrial cancer until proven otherwise, and an endometrial biopsy is necessary. So endometrial biopsy is the diagnostic test of choice for a patient with abnormal uterine bleeding or postmenopausal bleeding. It can be performed easily in the office using a pipelle, which is a catheter that is inserted through the vagina and the cervix into the uterus to sample the endometrium. A formal dilatation and curettage in the operating room is actually rarely required nowadays. Okay, classification of endometrial cancer. So the traditional histological classification is the following. So there are type 1 endometrial carcinomas, which are estrogen dependent, and type 2 endometrial adenocarcinomas, which are estrogen independent. Okay, and everything on this slide is very important. So the type 1 estrogen dependent adenocarcinoma, they are of endometrioid histological type. And they present in a background of atypical hyperplasia, which is the precursor for endometrioid carcinoma. They are the most common type. They represent 80% of all endometrioid carcinoma. They often present as low grade, well differentiated, and early stage, and therefore they have a better prognosis. The typical patient will be overweight, perimenopausal or early menopausal, so women in their 50s usually. Um, Estrogens play a very important role in the development of this cancer. This is why overweight patients have more risk of developing endometrioid carcinoma, because as we saw, peripheral fat can produce estrogen. So also patients that are known to have unopposed estrogen exposure. So other causes like PCOS patient that have an ovarian tumor that secretes estrogen, and we will see that and discuss that in the lecture on ovarian tumors. Patients who had early menarche and or late menopause, this means they have been exposed to estrogen longer in their life, so they're more at risk. Patients who take tamoxifen, extremely important. We discussed it before. Tamoxifen has a weak estrogenic effect on the endometrium and therefore can lead to endometrioid carcinoma. And finally, another risk factor is patients with Lynch syndrome who have MMR deficiency. So we discussed the Lynch syndrome in the neoplasia lecture last semester. So just a quick recall, Lynch syndrome patients have deficiency in the mismatch repair genes, and therefore they have difficulty to repair any damage to the DNA and have an increased risk of cancers, particularly cancers of the colon, cancer of the endometrium in females, and ovaries as well, and many others. Okay, and the last thing I want you to know is that endometrioid carcinoma, type 1 carcinoma, the main genes that can be mutated in these carcinoma are KRAS, PTEN, ARID1A, and beta-catenin, as well as MMR genes. Okay. Now for type 2 estrogen-independent cancer, that includes two different histotypes, serous carcinoma and clear cell carcinoma. We lump them into the type 2 because they are both estrogen independent and they present with the same, the patients have the same features. Okay, so they arise in a background of atrophic endometrium. Okay, so that's why in these patients an ultrasound to look for a thick endometrium will not be helpful because the background endometrium is atrophic and therefore thin. These cancers are always high grade and they often present at advanced stage. Therefore, they are more aggressive. The typical patient will be thinner and older menopausal patient in their 70s usually. The risk factor to develop a type 2 endometrial cancer is unknown, but what we know is that TP53 gene mutation is the driving alteration for the development of type 2 carcinomas, particularly in the serous subtype. Okay, so let's talk about atypical hyperplasia. So that is the precursor of endometrioid carcinoma. Now, very important to understand. Here, the term hyperplasia is a misnomer, right? In the neoplasia course, we discussed the concept of hyperplasia being a benign reactive process that can revert. Okay, this here, atypical hyperplasia, shouldn't have been named hyperplasia because it's truly a neoplastic proliferation. But this is the historical name and it's, we keep using it. In the last decade, there was a new term that was proposed, which is endometrial intraepithelial neoplasia, or EIN. It's been suggested to replace atypical hyperplasia, and that would make sense. But for some reason, it just hasn't gained any traction. So you could see both terms used, and it means exactly the same thing. So the causes and risk factor for atypical hyperplasia are the same as for endometrioid carcinoma because it is its precursor. If a patient is diagnosed with atypical hyperplasia, how do we manage that? Okay, so the definitive treatment is hysterectomy. So that will remove the hyperplasia and that will prevent its progression into carcinoma. However, some patients wish to preserve fertility, so like young patients that have PCOS and or any other underlying lesion that will lead to atypical hyperplasia at a young age, they may desire to keep their uterus for a while to maintain fertility. So in these patients, we can give them high dose progesterone that will uh, like reduce the growth and stun a bit the growth of the atypical hyperplasia and sometimes reverse it temporarily. Okay, so we can do that, but follow up with biopsies is essential with these patients because once you stop the progesterone, the likelihood is that the atypical hyperplasia will come back sooner or later and progress to cancer. A good option in terms of progesterone treatment is the Mirena, so the IUD that releases progesterone because it really provides a higher dose of progesterone locally, directly in the endometrium compared to the oral contraceptives. And it avoids all of the adverse systemic effects of oral contraceptives. Okay. How do we diagnose atypical hyperplasia? It's based on histological features, so we need two things. First, we need an increased gland to stroma ratio, so glandular crowding. And second, we need atypia. So you can see on the picture in the bottom, on the left, this is a normal endometrium. Okay, so the glands are sparse and there is quite a bit of stroma in between the glands. On the right side, this is atypical hyperplasia. So you can notice that the glands are much more crowded, very, very close to one another, almost back to back, and therefore the gland to stroma ratio is increased. Okay, and if you zoom in, like on the picture on top, you can compare a small benign gland to an atypical neoplastic gland, and you can see that the nuclei are much bigger, clearer with nucleoli. Occasionally, you can find mitosis too, so you can find atypia. Okay, so this is atypical hyperplasia. Okay, very important to note, the old classification of endometrial hyperplasia was making the distinction between atypical versus non-atypical hyperplasia, as well as complex architecture versus simple architecture. Okay, and that would lead to four different entities: simple non-atypical hyperplasia, simple atypical hyperplasia, complex non-atypical hyperplasia, and complex atypical hyperplasia. Okay, this classification is old, it's not reproducible, and it does not really translate into identifying real neoplastic lesions. So it should really not be used anymore. So either the hyperplasia is crowded and atypical, or it's not. It's not a neoplastic hyperplasia. Okay, so if atypical hyperplasia is not identified and or not treated, it will progress into an endometrioid adenocarcinoma. Okay, so these are examples. So you can see an endometrioid carcinoma, the picture on the left. So you can see that not only the glands are crowded, but they actually merge into one another. You cannot make the distinction between each individual gland. They merge. This is an architecture that is called cribriforming. So that's the hallmark of the carcinoma. Okay, so in hyperplasia, the glands don't merge. Once they start merging, it's a carcinoma. Okay, and as it progresses and it becomes higher grade, then we start to see more solid area with less gland forming, and that's how we will grade the endometrioid carcinoma. We use the FIGO grading system. So in a grade 1, there is less than 5% solid growth, so barely no solid growth. In a grade 2, there is 5 to 50% solid growth, and in the grade 3, the majority of the tumor, meaning more than 50%, exhibits solid growth. Okay, now, type 2 carcinomas, which we said are always high grade. So the main ones are serous carcinomas and clear cell carcinomas. I just want to show you a bit of histology on it, but you don't need to know that unless you want to do a pathology residency. So it's just for interest. So serous carcinoma is also called serous papillary carcinoma. We don't use that term anymore. We just say serous carcinoma. But the reason is that the main architectural feature of serous carcinoma is papillary growth. So finger-like projections within the lumens of the glands, as you can see. And the other thing, we said it's always high grade, so we'll really find severe atypia, very large nuclei with prominent nucleoli. Clear cell carcinoma, quite easy. So it's called clear cell carcinoma because the cytoplasm of the cells are clear because of the presence of glycogen. Okay, so this was the classic historical classification of endometrial cancer. In the last decade, there is a new classification that has emerged, which is called the molecular classification. And the reason that this has been developed is because the traditional histological classification is not always reproducible and can be imprecise. So even amongst gynae pathologists, sometimes we could look at an endometrial cancer and disagree on the subtypes. So that's why, there was all this work to try to identify the molecular profile of endometrial cancers and try to correlate it with behavior and prognosis, and to try to come up with something less subjective and more objective. Okay, so the new molecular classification is based on the tumor molecular profiles, and it's really now integrated into the management decision making process, but along with the traditional histologic classification. So what we do is that we do some testing on all endometrial cancers. We do their molecular profile, and we look particularly for mutations in poly. We also test for P53, and we test for MMR. And using the results of these three tests, we can characterize, classify the tumors into molecular classes and predict their behavior. So what we have found is that endometrial carcinomas that show a poly mutation have a favorable prognosis. Those that show a TP53 mutation have a worse prognosis, and this usually end up being the serous and the clear cells type 2. So that really correlates with, that subcategory in terms of prognosis and behavior. And then the tumors that show MMR deficiency have an intermediate prognosis. The tumors that show none of these, they are classified into the no specific molecular profile and also have an intermediate prognosis. Okay, having said that, how does an endometrial cancer spread if it is not treated? Okay, so endometrial carcinoma, as we said, arises in the endometrium, and then afterwards it will invade the underlying myometrium. So when the carcinoma is confined to the endometrium or the inner half of the myometrial wall, it's a stage 1A. If it invades deeper past, within the outer half of the myometrial wall, then it becomes a stage 1B. If ever it spreads downwards and invades into the cervical stroma, it is a stage 2. And if it invades, if it breaches the uterine serosa or reaches the tube, the ovary, or the vagina, it becomes a stage 3. Or also if it breaches the lymphatics and metastasizes to the pelvic or para-aortic lymph nodes, it's also a stage 3. Eventually, it can access the blood vessels and spread to distant organs. So Sites of predilection for metastatic endometrial cancer are usually the lungs and the liver. Okay, how do we manage patients with endometrial cancer? So the goal of the management is first we need to confirm a diagnosis, we need to treat, we need to relieve the symptoms, and we need to stage the tumor. The primary management of endometrial cancer is surgical. Hysterectomy is the gold standard. Bilateral salpingo-oophorectomy should also be done along with the hysterectomy for two reasons, mainly for staging purposes. So we want to assess whether or not the endometrial cancer has reached the ovaries and whether or not it is a stage 3, but also it's to reduce the, in a premenopausal patient, it's to remove the ovaries to reduce the estrogen production, particularly for estrogen-dependent endometrial cancer. Lymph nodes sampling is very important also for endometrial cancer for staging purposes. We do it only in patients that have a carcinoma that has high risk features. Okay, so serous clear cell carcinoma, type 2s, carcinomas that have a TP53 mutations will have lymph node staging. Afterwards, adjuvant chemotherapy and radiation therapy can be done if the cancer is of aggressive type or if it is at an advanced stage. Medical management by high-dose progesterone can be considered for premenopausal women that wish to keep their uterus to maintain their fertility, but that is only if the cancer is early stage on imaging and low grade on biopsy. And with the caveat that once the woman is done with childbearing, the uterus needs to come out. Another reason to do management by high-dose progesterone therapy is for women who are not surgical candidates for different reasons. Patients that have like severe cardiovascular disease, and the anesthesiologist estimates that the operative risk is too high for them. What's the prognosis of endometrial adenocarcinoma? On average, it's a good prognosis overall, with the caveat that prognosis is highly dependent on a few things. The tumor subtype, right? So type 1 endometrioid carcinomas have better prognosis. The grade, so grade 1 endometrioid are much better. And high-grade endometrioid or serous clear cell have a more aggressive behavior. The molecular profile, as we discussed, is important, and the stage at presentation. So if a patient is stage 1 at presentation, she has a 5-year survival rate of easily 95%. Screening and early detection for endometrial cancer, that is a big issue. There are no routine screening tests for endometrial cancer. Okay, so we cannot screen asymptomatic women. Okay, so we can only do endometrial biopsies in symptomatic women, and that becomes a diagnostic test, not a screening test. Okay, that is why it's very important that patients and family doctors are very aware of the symptoms of early endometrial cancer, which is, and very important again, postmenopausal bleeding. Okay, postmenopausal bleeding should prompt immediate medical evaluation to exclude or diagnose endometrial cancer early, because early detection will really improve prognosis and treatment outcomes. Okay, so if we cannot screen, at least can we prevent it altogether? Well, yes and no. There are a few things that can be done. So type 1 endometrioid carcinoma, we said is estrogen dependent. So it's important for patients for women in general, to maintain a normal BMI with healthy diet and exercise. Because we saw that, obesity is an important risk factor for endometrioid carcinoma. It's very also important to detect PCOS, polycystic ovarian syndrome, early and to follow the patients and treat them with maintenance progestin therapy to prevent the development of atypical hyperplasia and endometrioid carcinoma. Once a patient is diagnosed with the precursor atypical hyperplasia, very important to manage it, either surgically or medically, to prevent its progression to endometrioid carcinoma. And finally, important to document the family history of our patients in order to detect patients and their families that may have Lynch syndrome. Okay. And in those patients, we can offer a risk-reducing prophylactic hysterectomy. So after the patient is done with childbearing, okay, a patient with Lynch syndrome should have hysterectomy with bilateral saphenous oophorectomy because, as we will see, Lynch patients do have an increased risk also of ovarian cancer. For type 2 serous and clear cell carcinomas, there are no known prevention strategies identified so far. Okay, so we talked about the uterine adenocarcinomas, so now let's talk about the sarcomas, and I will limit the discussion to the leiomyosarcomas. So uterine sarcomas are quite rare, less than 10% of uterine malignancies, but they are aggressive. Okay, leiomyosarcoma, which is the malignant sarcoma of the smooth muscle, myometrial smooth muscle, is the most common type of uterine sarcomas. Very important to know is that leiomyosarc arise de novo. Okay, they are not a malignant transformation of a leiomyoma. Okay, they arise de novo. The typical presentation, the typical patient is a perimenopausal woman that presents with abnormal bleeding and a uterine intramyometrial mass that is identified on imaging. So how do we confirm the diagnosis? To diagnose a leiomyosarcoma, we absolutely need to examine the hysterectomy specimen. Okay, that is required. Leiomyosarcomas can be suspected on imaging, particularly if invasion within the surrounding tissue or necrosis are seen. But leiomyosarcomas are often mistaken by radiologists for benign leiomyoma. And also important to note, endometrial biopsy usually cannot sample a leiomyosarcoma because these are located within the myometrium, and the biopsy will only sample the endometrium. Okay, so here's a hysterectomy that is open with a very large leiomyosarcoma that almost replaces the entire myometrial wall. Okay, what does it look like? It's an intramyometrial solitary mass with necrosis. Okay, we can see some necrosis here. And it's a mass that is irregular. Okay, the borders are not well defined. I have a difficulty to really define it. It infiltrates the surrounding myometrium. On histology, it will show malignant spindle-shaped cells similar to the smooth muscle spindle cells from which they arise. But these malignant cells will show atypia, mitosis, and necrosis. So these are the three main diagnostic features of a leiomyosarcoma: atypia, mitosis, and necrosis. How do we manage patients with leiomyosarcoma? So hysterectomy is mandatory for diagnostic confirmation and for treatment. Bilateral saphenous oophorectomy should also be done first for staging purposes to see if the sarcoma has spread to the annexa, but also to control the hormone levels because most leiomyosarcomas will be hormone sensitive. We do not do lymph node sampling for leiomyosarcomas. Remember from the lecture on neoplasia, sarcomas do not spread through lymphatics into the lymph nodes, right? They tend more to spread, they use the blood vessels and spread distantly. So there is really no role for lymph node sampling in leiomyosarcomas. Chemotherapy, radiation therapy, and hormonal therapy, they have limited effect but they can be attempted as an adjuvant therapy for patients that are advanced stage or that have recurrent tumors. What's the prognosis? Leiomyosarcs are very aggressive tumors. They have a high recurrence rate and a low 5-year survival rate. There is some variation and mainly based on tumor size and stage. So if a patient that has very small tumor confined to the uterus may have some chance, but otherwise it's usually an aggressive tumor because they tend to breach the blood vessels and spread hematogenously, mainly to the lungs. Okay, this is a very important slide. Okay, that's why there's a picture of somebody taking a test right here. Okay, you need to know this slide. So we said a leiomyosarcoma presents as a uterine mass, but you need to remove the uterus and do a hysterectomy to confirm the diagnosis. So a lot of patients have uterine masses. We saw earlier in the lecture that fibroids, leiomyomas, are very frequent. So if you have to remove the uterus to make the diagnosis of sarcoma, so how can you deal with this multitude of patients that probably just have a leiomyoma? So you need to know the clinical differences between a leiomyoma and a leiomyosarcoma to assess what is the risk that this patient, maybe the rare one that has a sarcoma, and identify her early and go ahead with the hysterectomy. Okay, so leiomyomas, and this is very important again, okay, as we see, they are benign and they are common, while sarcomas are malignant and rare. Leiomyoma will tend to grow slowly. This is very important. And usually in in the premenopausal state. And once the patient reached the menopause, they can shrink because they are very estrogen dependent. Leiomyosarcomas will grow rapidly and they will continue to grow even after menopause. Okay, that's a very important clinical distinction. Leiomyomas usually present as multiple lesions, while leiomyosarcoma usually present as a solitary mass. So if you have a patient that presents with a rapidly growing solitary uterine mass that keeps growing even if though she's menopause, you should be very alarmed about that. Now that after the uterus is removed, the differences that the pathologist will notice is that, as we said earlier, leiomyoma is well circumscribed, white, well firm, and shows bland spindle cells, while the leiomyosarcoma is infiltrative, is more tan, soft with necrosis, and shows on histology atypical spindle cells with necrosis and mitosis. Okay, so this concludes our talk on diseases of the uterus. Again, if you have any questions, please do not hesitate to reach me at the email address written on the slide. So Dr. Valérie Dubé, Gaza at yahoo.com.